السلام عليكم دكتور أحمد.
وعليكم السلام ورحمة الله وبركاته. الصوت واضح دكتور إيمان؟
أي استعدنا ويشرفنا جدا وجود حضرتك معانا للسنة الثانية على التوالي في المؤتمر. شرف كبير وجود حضرتك معانا، وإن شاء الله بإذن الله الحضور الكريم كله في اشتياق إن هو يسمع علم حضرتك الغزير، ونستعدنا بمحاضرة حضرتك إن شاء الله يا دكتور أحمد.
شكرا، الشرف لي حقيقة أني أكون معكم في هذا المؤتمر العالمي.
We are now introducing session 2, session of Meet the International Guest Speaker. In this session, we welcome Professor Ahmed Bahammam, our international guest speaker from Saudi Arabia, and the title of his presentation today will be Primary Snoring, Bridging Gaps in Management and Research.
السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم. Good morning ladies and gentlemen. حقيقة أنا أتشرف أني أكون معكم اليوم في هذا المؤتمر العالمي مع أشقائي في مصر، وشكر خاص لمعالي رئيس المؤتمر، وشكر خاص أيضا للبروفيسور إيمان جلال لدعوتي. The presentation will be titled Primary Snoring, Bridging Gaps in Management and Research. This is an important topic that deserves a lot of attention. I'll time myself. If we look to the outlines of this talk, the first 5 minutes I'll try to go quickly over the definition of primary snoring, prevalence, and current management. Then I'll spend the rest of the talk talking about the gaps in research and the recommendation for better research. This is a hot topic in the literature now. And the support for this is that Sleep Medicine Review, which is the top journal in the field with an impact factor of more than 11, published this work. This is my paper. For more details, you can get it. It has been published this month, October 2024. So when we talk about primary snoring, the definition is not clear. We know that there is snoring, as you can see in this epoch of the polysomnography, but breathing is normal and there is no desaturation. But there is no agreement on the best AHI or RDI index for that. The prevalence have been reported with varying degrees. This is a systematic review of 35 studies that showed high prevalence of snoring in both males and females, but more in males as we would expect. But what's interesting here is to see that the range of prevalence is very wide, from 2.6 to 83%, indicating that we don't have proper measurement tools for snoring. If we look to local data, this is the snoring in middle age group. The green is Saudi Arabia, and this is in the West. We see that middle-aged men around more than 50% snore compared to the West. But in women, in Saudi Arabia, middle-aged women, it's higher than females. You see down here, 21%, which reflect probably the higher prevalence of obesity in middle-aged women in our area. Is there something called benign snoring? Because this is something that we were hearing before, and this is an editorial from CHEST, published 20 years ago by Christian Guilleminault, one of the top leaders in sleep medicine. And this is a photo or a drawing from my encyclopedia online showing that this, initially we thought this is a joke. But is it a joke? Maybe it is not a joke. There is nothing called primary snoring. I'll try briefly to look into the impact of primary snoring in health, mainly cardiovascular and metabolic. In this study published recently this year in Nature Digital Medicine, they found that the duration of snoring is associated with a twofold increased risk of uncontrolled hypertension when they account for sleep apnea. Also, this is another recent study from China. They followed patients for 10 years. They have 130,000 population. They found something interesting, that those who are less than 50 years baseline and they snore, they have increased risk of all cardiovascular risk factors, even after controlling for systemic hypertension. So it's not a benign problem. And this is another figure from the same study. This is a study that looked into metabolic syndrome. Again, a recent study from China. They found something interesting after they controlled for apnea and hypoxia. They found that snorers, they have higher risk of metabolic syndrome, especially among women. So sex probably affect snoring complication as well as age. While cardiovascular risk was higher in men, metabolic syndrome was higher in women, and they put some theories for proposal. Another important side effect of snoring, which is not well addressed in the literature, is the impact on the bed partner and family. Studies have shown that the bed partner, they have higher daytime sleepiness, poor sleep, more mental health, and depression and headache. And it can result in divorce in some cases. This is a recent scoping review of the management of primary snoring, again published in Sleep Medicine Review, October 2024. I will not go into the details of that because this is not the objective of my talk, but you can review this paper for more details. They reviewed both conservative non-surgical options and surgical options for primary snoring, and they concluded that we don't have good evidence yet. In the scoping review, they have 6 domain outcomes defined in different studies, ranging from physical function, side effects, quality of life. But the main point I want to point here that most of the study reported subjective snoring only, not objective, subjective. What does that mean? It's not clearly known. And daytime sleepiness. And they use different instruments, including non-validated subjective tools. Now I'll move to the core of the lecture, which is the gaps. What gaps do we have in research that we need to fill? And this is an area for postgraduate students who are doing research now and for researchers who are interested in sleep medicine. Gap 1, lack of consensus on primary snoring definition. Studies have reported different definition for primary snoring using different AHI, which is the apnea-hypopnea index. So there is lack of consistency in diagnostic criteria across different studies. And there is a need for standardized diagnostic criteria. We have to ensure that all future studies use the same criterion to define primary snoring so we can compare different studies. Gap number 2, limited high quality evidence. Most of the studies, 60% or more, they are observational before and after. There is no remarkable trend increase in randomized control trials over time. Moreover, they have small sample size with a randomized or non-RCTs ranging from 20 to 80 patients. With that small number, you cannot reach a solid conclusion. Gap number 3, heterogeneity in outcome measures. There's a wide range of outcome across studies with 26 different outcomes, and most of them were subjective snoring level. They didn't assess like comorbidities, domestic life, and quality of life, and health outcome. There is also lack of standardization in measurement instruments. They use 59 different instruments to assess snoring. Most of them were subjective and non-validated. Gap number 4, underrepresentation of partner relevant outcome. I spent some time in this. This is very important. There is limited assessment of the impact on bed partners. Only 4 out of 26 outcomes accounted for that. So there is a need for more comprehensive evaluation of treatment effects on family and bed partner. And future research should address more partner-relevant endpoints. Gap number 5, limited economic evaluation. There is lack of cost-effectiveness analysis from the patient perspective and healthcare providers at the level of effectiveness and cost, which modality is better. So there is a need for assessment of affordability and resource utilization. Affordability for healthcare systems and patients should be evaluated. Also, utilization data needed to estimate real-world cost and budget impact. This is a very important fact in the current era. Gap number 6, inconsistent reporting of participant characteristics. There is incomplete reporting of age and sex in many studies. And from what I showed you before, we know that age and sex, they made difference in the outcome. Also, importance for assessing heterogeneity and subgroup analysis. We know now that different disorders, they have different phenotypes and endotypes with different clustering. Not one size fits all for all kinds of patients. So we need to have that subgroup analysis and clustering that will help in the diagnosis and tailoring management, or what we call precision medicine. Gap number 7, limited long-term follow-up. Studies that have been reported follow-up ranged from 1 day to 9 years. with a median follow-up of 6 months. So there is a need for assessment of long-term efficacy and safety. There is a paucity of studies evaluating outcome beyond 1 year. We don't know after that what happened. Do the patient sustain the improvement? Do they have other side effects, comorbidities? We don't know. Now I'll move to the recommendations, and this is for researchers mainly and clinicians. What areas that we need to work on as researchers? Recommendation number 1, we need to standardize primary snoring definition. We need to adopt a consistent AHI or RDI, cutoff probably less than 5, to make sure this is primary snoring. We need to ensure clear differentiation from obstructive sleep apnea, because some of the reported studies did not differentiate the existence of sleep apnea in those patients. Recommendation number 2, we need to conduct more high-quality RCTs. This is very important. We have also to have proper power calculation and sample size to determine the exact sample size. Also, we need to consider multi-center trials to achieve larger samples and to account for race diversity, because studies from China may not apply to our area, to Arabs in our region. We need also to compare effectiveness of different intervention, whether surgical or non-surgical. And for that, we can use network meta-analysis. I'll come to that in the coming slide. Recommendation number 3, we need to develop a core outcome set, very clear outcome set. We need to standardize outcome measure across studies, prioritize a minimum set of outcomes, achieve consensus on how these outcomes should be measured, and what outcomes are important from the patient perspective and the healthcare provider and bed partner. We need also to facilitate meta-analyses and evidence synthesis. We'll talk about this in more details. Recommendation number 4, this is for the partner relevant outcome, and this is very important. I'll spend some time here because for us, even as physicians or surgeons, we don't ask much about the bed partner. We focus on the patient and we don't care much about the bed partner, what's happening to them. We should pay attention to this. Snoring and OSA significantly affect the sleep quality of bed partners. There are few studies on that, but one good study, though it's old in Mayo Clinic proceeding, showed that partners of those who snore gained approximately 62 additional minutes of sleep per night when snoring was treated with CPAP. I'll spend some time on this slide. This is for women. Women face embarrassment and stigma for labeling them as snorer because they consider this as effeminate. This is something for males. So even if your female patient has snoring, she may not declare that. Not only that, because they feel embarrassment. One more thing, women are unlikely to complain about their husband snoring. So they may suffer with insomnia, mental illness, headache in the morning, daytime sleep, but they don't complain. On the contrary, men complain if their wife snores. So women living with heavy snorers experience adverse health outcome. We discussed that. More frequently affected by insomnia, morning headaches, daytime sleepiness, and fatigue. And some of them, they sleep in separate rooms. But studies have shown that sleeping in a separate bedroom did not alleviate the symptoms for women that we discussed, or the mental health, or the family life. So it's important that we assess the impact of management on bed partners, sleep quality and quality of life, quality of sleep, using validated measures, daytime sleepiness, quality of life, and domestic problems within the family because of snoring. This is a serious business here. Also, we need to evaluate partner satisfaction with treatment outcomes. We don't just depend on the patient report and objective measures. We have to ask the bed partner, what do you think of this treatment when we measure the outcome? Recommendation 5, conduct economic evaluation. Very important. We need cost effectiveness for different modalities of treatment or interventions. And we need to compare surgical versus non-surgical. Which one is effective and has lower cost? Also, we have to consider affordability and resource utilization in the current era of cutting on the budget of health providers. So we have to assess that from the healthcare system and patient perspectives, from both perspectives, which one is more effective. Recommendation number 6, improve reporting quality. Most of the studies that have been reviewed, they don't have proper reporting. So if we have RCT, we have to adhere to the consult guidelines clearly to have good outcome. And if we have observational studies, then we have to follow the STROBE guidelines. It's very important that we have to follow. We have to ensure complete reporting of participant characteristics, including age and sex, very important. Some studies, they do not do sub-analysis for age and sex. Also, we have to include relevant comorbidities, whether the patient have coexisting comorbidities like cardiovascular diabetes, metabolic problems, and medications, very important. And snoring severity. Severity, we don't know how to measure it yet. I'll come to that as one of the recommendations. And we have to conduct, number 7, long-term follow-up studies. We need that. We need to go beyond 1 year to assess the efficacy and safety over extended periods. And we need to evaluate the durability of treatment effects, because do patients lose this beneficial initial effect after 1 or 2 years? Something we have to keep in mind. Recommendation number 8, very important, and we had a lecture before about artificial intelligence. We need now to utilize AI for primary snoring and precision medicine. We need to develop AI models to analyze snoring sounds for early OSA screening. This can be done at home easily. We need to use deep learning transformers to differentiate primary snoring from sleep apnea. We need to integrate AI snoring analysis into clinical workflow and create diverse data sets. We need to combine AI with biomarkers for what we call personalized medicine for OSA and precision medicine for treatment, because again, not one size fits all. We have to go and tailor treatment to the specific patient. We need to conduct large-scale validation studies of these AI models. And finally, and very importantly, we need to have personalized treatment. And this is we are in the era of precision medicine, that we have to go and use personalized treatment for specific patients to improve outcome and efficiency workflow. So I'll conclude with these 3 slides, and probably we'll have some time for questions. What are the future research directions? We need to do network meta-analyses. What's network meta-analyses? Network meta-analyses meaning even if studies are done by surgeons and studies done by dentists on the mandibular advancement devices and studies done by pulmonologists on CPAP, in this meta-analysis, we can collect studies with different interventions and compare them head-to-head in this analysis. This is called network meta-analysis, to compare multiple interventions. We need to develop a validation of objective snoring measures, and for that, we can use acoustic analysis and also implement AI. We need to correlate objectives measure with patient satisfaction and bed partner satisfaction, very important. We need to investigate novel treatment. And recently, there is a paper in the New England about tirzepatide, which is dual GIP GLP-1, that showed that it decreases sleep apnea. So as non-interventional or a medication, maybe it can be tried for patients with primary snoring. No studies on that yet. Implication for the clinical practice, we need evidence-based treatment guidelines. For that, we need more research and we need network meta-analysis. Again, the importance of individualized treatment selection. We cannot apply one approach like surgical or mandibular advancement device to all patients. For that, we need to have multidisciplinary approach involving all stakeholders, sleep specialists, otolaryngologists, dentists, and patients and their bed partners to see what's the best modality for each patient. And also we need to have consideration for patient preferences and the impact of snoring in the bed partner. So to conclude, and I left intentionally some time because if there are questions related to this, summary of key gaps and recommendation, we discussed that. There is lack of consensus on primary snoring definition and outcome measures. There is a need for more high-quality randomized controlled trials with standardized reporting. The importance of evaluating partner-relevant outcomes and cost is very important because also they will support the patient with the modality of treatment they have. Also, there is a call for action for researchers and clinicians. We need to prioritize research to address identified gaps that we discussed, and we need to collaborate to develop core outcome sets that involve all stakeholders, not only the therapist or health providers, but also the patient and the bed partner. And we need also to provide patient-centered and bed partner-centered evidence-based care for primary snoring, not just dependent on having a BSG after that or home sleep study and say, now you have no snoring, we don't record that. That's important, but we have to look into the patient and keep our approach always patient-centered. And thank you.
Thank you, Professor Ahmed. And let me ask you the first question. Based on your great experience in this field, when you meet patients with primary snoring, what's the plan of management for such patients from your own experience?
As we discussed, the first point for the attendees that we have to rule out sleep disorder breathing, like sleep apnea or obstructive hypoventilation, because for that we'll go with CPAP as the first modality of treatment. If we exclude completely obstructive sleep apnea or upper airway resistance syndrome, then we have two options. We send the patient for evaluation by a surgeon who is specialized in sleep medicine surgery, and to a dentist who is specialized also in sleep medicine dentistry. Both of them, they will evaluate the patient, and then we try to hold like a conference meeting and choose what's the best modality they think will be for that patient. Also, we approach if the patient is like obese and willing to go through a program for weight loss, we tell them that probably if you lose weight, snoring will disappear. So we explore also that option. Then we discuss with the patient and the bed partner what are the options they have and what are the recommendations from the otolaryngologist and the dentistry colleagues and what the family preference, and we go with that.
When you choose between the oral appliances, do you go for the customized oral appliances for patients with primary snorer, or you go for the ready-to-use ones?
The evidence for the ready-to-use ones is not good, and there is no evidence for it yet, though it is promoted by companies and has not been included in any guidelines because there is no good evidence. So the evidence now from the American Academy of Sleep Medicine or even the dentistry sleep medicine specialist is to go with the designed one, because the mandibular advancement devices are not good for all patients. Those probably with a small, very small mandible may not work for them. Again, they have to assess the teeth, how good are they. So the recommendation is to go with the designed one for now.
I recently introduced to the market the Ospolot for the treatment of primary snoring. I want to ask about your experience with this medication, because we don't here have any experience with this medication in primary snoring in Egypt. Based on your experience, is it effective in patients with primary snoring?
Sorry, which medication?
Ospolot, the carbonic anhydrase inhibitor, the sulfadione.
Okay, yes. No, carbonic anhydrase inhibitors have been proposed for patients like with central sleep apnea and patients also with hypercapnia. But the problem with these medications that they are effective initially for any kind of sleep disorder breathing, but with follow-up they lose their effect. So it is a temporary effect. And I think there are no good long-term data showing the sustainability of the beneficial effect.
Does hypoglossal nerve stimulation have a good role here in patients with primary snoring?
There are no data on that. This has been used for patients with sleep apnea, and with that, snoring disappeared. So snoring disappeared for these patients with hypoglossal nerve stimulation, but to go and do it only for snoring without sleep apnea, even in the West, this is not yet covered by insurance companies to treat primary snoring only.
Thank you, Professor Ahmed. Thank you for this thoroughly emphasized presentation about the primary snoring. Another audience, what else?
Thank you for excellent presentation, Professor Ahmed. I would like to ask about how to expect or predict person, not patient, person with private snoring to or lead to progressive sleep apnea. Which type?
Yes,
كلنا بنسنور.
Yeah, this is, Professor, a very important and practical question, and this is an area for research. The slide which I presented, one of the last slides about the AI, I didn't have time to discuss the picture, but the picture was showing an early work to analyze the frequency of the snoring and how to differentiate, probably if we call pathogenic snoring from other sounds. And this is an area for research that we need to look at and to analyze the frequency and acoustic data from the sound itself, and with the follow-up if it is linked to the development of comorbidities. But we know from data now that the duration of snoring, the longer the duration of snoring, if someone snores most of the night, we know this from observational studies that followed patients for a long time, the longer the duration, the higher the risk of cardiovascular and cerebrovascular complications, even if there is no sleep apnea.
Professor Ahmed, on behalf of the Egyptian Society of Chest Disease and Tuberculosis, and me personally, we appreciate very much your contribution in our meeting. We hope next year to see you personally here in Egypt. Thank you very much.
شكرا معالي الوزير، انا حقيقة تشرفت بلقائك الان ولقائك سابقا في بعض السفرات خارج مصر، واسعد دائم بلقائك واتشرف بلقائك معالي الوزير.
وانا يسعدني دايما تكون حضرتك معانا وتشرفنا، عشان يعني الاكسبيرينسز العربيه والمصريه والسعوديه في different fields of pulmonary medicine الحقيقه will be appreciated. حضرتك عارف ان احنا عملنا اول سليب لاب في مصر هنا من سنوات طويله جدا، والحمد لله الاجيال المختلفه بتعمل مور كونتريبيوشن وادفانسز جديده في هذا الفيلد بيتم تطبيقها. واحنا الحقيقه لما نتبادل الخبره العربيه وطبعا بنستفيد من الاوروبيه العربيه، الحقيقه ده يعني فاليو جديد لديفرنت فيلدز ان بالمونري ميديسن. حاجه انا بشكرك جدا وسعيد بوجودك معانا، والمحاضره الحقيقه يعني اكسلنت ريفيو عن التوبيك اللي حضرتك اتكلمت فيه.
شكرا معاليك. والشيء بالشيء يذكر في اسيا الان انا ارأس الجمعيه الاسيويه لطب النوم، وفي اسيا في الاسبوع الماضي we launched the Asian Adult Sleep Medicine Fellowship Training Program, a huge document to develop an adult sleep medicine fellowship program for all Asian countries. We have 48 countries in Asia, and it's a document of 120 pages, and this has been submitted now as a paper to the American Academy of Sleep Medicine. So probably in the future we can collaborate on that, on the training, and if it's something like for Africa or for other parts in Africa, we can probably collaborate with the Asian Society in developing the training across continents which do not have the same standards in different countries. Like, for example, in Asia, we have Japan, then we have countries like X, I will not name countries, with a different standard. Not like in Europe, where they have close standards, or in the US, where they have the same standards. I think probably the same thing in Africa. We have probably Egypt, high standards, but then we have other, Egypt, probably South Africa, then we have X country, which has lower standards and healthcare resources. So this is something probably we can collaborate on in the future.
ألف شكر، ونشوف حضرتك بخير، وكل سنة وحضرتك طيب، وشكرا جزيلا.
شكرا لكم.